Hello everyone, my name is Hamza Hashmi. I'm a multiple myeloma physician from Medical University of South Carolina. In my practice, I focus on cellular immunotherapy for myeloma. And today I will be talking about some of the highlights for myeloma from ASCO 2023. I will be talking about some of the important abstracts and presentations. When I do that, I will be quickly discussing the summary and highlights of the trials and presentations, including the patient population, the trial design, safety and efficacy data. And then I will be walking you through how the trial was conducted, what could have been done better, and how the trial and the results actually impact our outcomes of future research. The very first abstract, which was presented in an oral presentation in ASCO 2023, is CARTITUDE-4. Given the significance of this oral abstract, it was not surprising that it was actually simultaneously published in NEJM, and it will likely lead to approval of this CAR T cell therapy for patients with relapsed myeloma in the earlier lines of therapy. This was a phase 3 randomized control trial that actually compared cilta-cel versus standard of care chemotherapy, namely dara-pom-dex and bortezomib-pom-dex, in patients with relapsed myeloma, 1 to 3 prior lines of therapy, and patients who were lenalidomide refractory. In this flow diagram, you can see that a total of 420 patients randomized 1-to-1. You can see that nearly 15% of the patients who actually underwent leukapheresis were not able to receive infusion of the CAR T cells because of disease progression or death, whereas almost all of the patients who were randomized to the standard of care arm were able to receive chemotherapy. So you will see an as treated analysis and also an intent to treat analysis. And you have to remember that not all of the patients who underwent leukapheresis actually received infusion of the CAR T. Highlighting some of the important features of the patient population, you can see that in this particular trial, 20% of the patient in each arm had extramedullary disease, 20% had high disease burden in the bone marrow. On average, patient had received about 2 prior lines of therapy. This trial was enriched for high-risk cytogenetics myeloma, with nearly 60% of the patients in each arm having high-risk cytogenetics and 20% of the patients actually having double-hit myeloma. Important thing to highlight here would be that in the standard of care arm, where patients are receiving dara-pom-dex or bortezomib-pom-dex, nearly 20% of the patients are either refractory to bortezomib or refractory to daratumumab, yet they received dara-pom-dex and bortezomib-pom-dex as salvage therapies upon their relapse on lenalidomide. Looking at the efficacy data, you can see that the cilta-cel arm clearly had superior depth of remission, with nearly 85% of the patients achieving a response and complete remission seen in nearly 75% of the patients. Similarly, at the median follow-up of 15 months, the median progression-free survival for the cilta-cel arm was not reached and was nearly 12 months for patients on standard of care chemotherapy arm. It's important to highlight here that this is an intent to treat analysis. If you look at as treated analysis, response rates for cilta-cel was as high as nearly 90%, with vast majority of these responses being complete remission. Here you can see the safety outcomes on this particular trial. Universally, we saw neutropenia, anemia, and thrombocytopenia. Grade 3 or higher were actually seen in 90% of the patients. But one important thing to highlight here is that resolution to grade 2 or lower cytopenia within 1 month of CAR T was seen in a vast majority of patients. This is something that we don't typically see with CAR T cell therapy with its current approval in relapsed refractory myeloma after 4 prior lines of therapy, and hence clearly speaks to the fact that when CAR T is used in earlier lines of therapy for not as heavily pretreated myeloma, that cytopenias that occur after CAR T actually resolve in a much faster manner. If you look at other toxicities associated with CAR T, CRS was again seen in 75% of the patients, vast majority grade 1 or grade 2. There was ICANS neurotoxicity seen in about 20% of the patients, which is not different from what we have seen before. Again, you can see that the incidence of CRS is not as high as we have seen in CAR T being used in later lines of therapy. An important thing to highlight here would be non-ICANS neurotoxicity with cranial nerve palsy, especially 7th nerve palsy seen in some patients, as well as peripheral neuropathy. It's important to highlight that these toxicities, they actually occur beyond first 2 to 3 weeks, and they can actually linger on for a while and do not always resolve. These neurotoxicities have not been clearly understood, and despite having these patients undergo bridging therapy, still can occur. So my take-home messages from CARTITUDE-4 trial are that cilta-cel, when compared to standard of care chemotherapy like dara-pom-dex or pom bortezomib-dex, has superior depth and duration of remission. Now, how that would compare to perhaps a stronger comparator arm in the form of dara carfilzomib dex, it remains unknown. More importantly, having access to CAR-T will be critical, knowing that cilta-cel is only available at certain handful of centers in US, and using it in earlier line of therapy will actually make many more patients eligible and hence increase the demand for cilta-cel. To be able to meet that demand in time is important. Another important point here is that in order to manufacture cilta-cel, it can take up to nearly 90 days or 3 months, requiring at least 2 cycles of bridging chemotherapy. And that's perhaps one of the reasons that some of the patients either progressed or died while waiting for the CAR-Ts to be infused after leukapheresis. And hence we see the differences between the intent to treat and as treated analysis. It is clear to me that the side effect profile in the form of CRS and cytopenias is not as severe as it is when you use CAR-T for later lines of therapy. And hence, with early resolution of cytopenias and perhaps a lower incidence of CRS, use of CAR-T in the earlier lines of therapy will be preferred. What is also important to highlight is a non-ICANS neurotoxicity that still exists in the form of cranial nerve palsies and peripheral neuropathy that don't always resolve with interventions that we are aware of. Hence, giving these patients bridging chemotherapy, having close monitoring of their handwriting, and giving them early dexamethasone will be important when taking them to cilta-cel. I think at the end of the day, if cilta-cel does get approved for relapsed myeloma after 1 to 2 prior lines of therapy, it will be a discussion between the patient and the physician, and perhaps a one-and-done option which appear to be much more attractive to a patient than being on continuous chemotherapy in the form of darapam dex or pembrolizumab dex that does have its own side effects.
Next in line is a TRIM2 trial, which actually looked at combination of talquetamab and daratumumab in patients with relapsed refractory myeloma, with many of these patients having had exposure to refractoriness to daratumumab and received prior bispecifics in this particular trial. Patients in this study received subcutaneous daratumumab as per schedule. They received talquetamab either at a dose of 0.4 milligram per kilogram weekly or 0.8 milligram per kilogram every 2 weeks. For a safety and efficacy analysis, we'll focus on the 0.8 milligram per kilogram every 2 weeks talquetamab group. You can see that they were heavily pretreated with at least 5 prior lines of therapy. 90% of the patient had prior exposure to either dara or ESA, and 80% of them were refractory to anti-CD38 antibody. At least 60% of the patients were triple class refractory, and 20% of the patients had refractoriness to prior bispecific agents. At a median follow-up of 15 months, 85% of the patients in the 0.8 milligram per kilogram every 2 weeks talquetamab group had actually achieved a response, with the vast majority of these responses being very good partial remission or better. Median progression-free survival was nearly 18 months, and median overall survival was not reached. 12-month estimated PFS and OS was actually 66% and nearly 90%. A very important point to highlight here is the overall response rate in patients who had prior exposure and, more importantly, refractoriness to anti-CD38 antibody. You can see that the response rate was sustained at nearly 80% in patients who were refractory to prior dara or isatuximab. CRS was seen in 80% of the patients. All of these events were grade 1 or grade 2. All of these events occurred with a step-up dosing or within the first cycle. Very few cases of ICANS grade 1 or grade 2 were seen. These CRS and ICANS were actually manageable with tocilizumab and acetaminophen, very few patients actually requiring corticosteroids. So the addition of daratumumab to talquetamab did not adversely affect the CRS and ICANS profile associated with this bispecific T-cell engager. An important side effect of both bispecifics and anti-CD38 antibodies is hypogammaglobulinemia, leading to infections and the need for IVIG. You can see here that nearly 75% of the patients developed an infection, with 25% of these infections grade 3 or higher. 25% of the patients actually got a COVID-19 infection. 10% of the patients developed opportunistic infections like PJP, and there were patients who actually had CMV reactivations as well. Nearly 85% of the patients developed hypogammaglobulinemia after getting treatment, and 1/3 of these patients required IVIG. So very clearly, the addition of daratumumab to talquetamab led to a high incidence of hypogammaglobulinemia infections, necessitating the use of IVIG with these therapies. Authors concluded that combination of talquetamab and daratumumab led to a high response rate of nearly 85%, median duration of response lasting nearly 18 months, at the cost of no increased incidence of CRS or ICANS, but some hypogammaglobulinemia and infections. I think the important question here would be that patients with prior exposure and more importantly refractoriness to daratumumab, do they really need a combination of both talquetamab and daratumumab to get an additional 10 to 15% increase in the response rate at the cost of high incidence and severity of hypogammaglobulinemia leading to infections and necessitating the use of IVIG? Next in line is the Redirect 1 study that evaluated the combination of teclistamab, a BCMA targeting bispecific, and talquetamab, a GPRC5D targeting bispecific agent for patients with relapsed refractory multiple myeloma. This was a phase 1b study, and we will focus on RP2D with teclistamab given at 3 mg per kilogram and talquetamab given at 0.8 mg per kilogram every 2 weeks in subcutaneous manner. You can look at the patient populations, and they were heavily pre-treated relapsed refractory high-risk myeloma patients, with at least 1/3 of the patients having extramedullary disease, having high-risk cytogenetics, at least 4 median prior lines of therapy. Vast majority were actually triple class refractory, nearly 80%, and almost all of these patients were refractory to the last line of therapy. Looking at the efficacy data first, combination of teclistamab and talquetamab was associated with a very resounding 95% response rate, with a majority, nearly 40% of these responses being complete remissions or better. With a median follow-up of nearly 8 months, median progression-free survival and duration of response were actually not achieved, and 9-month estimated PFS was nearly 80%. Focusing on the high-risk disease category of extramedullary myeloma, we can see that nearly 85% of these patients actually had a response, with 1/3 of these patients actually achieving complete remission. At a median follow-up of nearly 7 months for this high-risk category, median PFS was nearly 10 months. Knowing that extramedullary myeloma is a high-risk category where we don't typically see as deep and durable responses with either bispecific CAR-T, I think these responses seen here are perhaps the highlight of this particular abstract and study. Combination of these two bispecifics was associated with a CRS incidence of nearly 75%. Again, almost all of these events were grade 1 or 2. They occurred during step-up dosing or during the first cycle, and they were manageable overall with use of tocilizumab. Combination of these two bispecifics was again associated with a high incidence of infection, nearly 80%, with more than 1/3 of these infections grade 3 or higher, including infections with COVID-19 as well as pneumonias. Focusing on individual toxicities, especially for talquetamab, you can see that nearly 40 to 50% of these patients developed side effects of dysgeusia, skin toxicity, and nail disorders. Authors concluded the combination of teclistamab and talquetamab led to very deep and durable responses. This was especially true for patients who had extramedullary disease. The combination was associated with no significant increase in the risk of CRS and ICANS, but a high incidence and severity of infections associated with the combination. So I believe that perhaps this combination may be a good option for patients who have extramedullary myeloma, who have not had any prior exposure or refractoriness to teclistamab or talquetamab. But whether this combination of bispecifics can be used for patients who do not have extramedullary disease remains to be determined, especially knowing that they are associated with a very high incidence and severity of infections. Switching gears here and moving on to a new theme of rapid manufacturing of CAR-T products. Dr. Sperling and his co-investigators presented the updated results of phase 1 study of PHE885 with ex vivo manufacturing, in vivo expansion, reducing vein-to-vein time in patients with relapsed refractory myeloma. We are aware that commercially approved CAR-T products have manufacture time anywhere from 4 to 8 weeks, with a vein-to-vein time anywhere from 6 to 12 weeks, requiring bridging chemotherapy, sometimes even 2 or more cycles of it. To address this problem, there has been a focus on developing rapid manufacturing of CAR-T, and this is what this study looked at. In this particular study, 50 patients received a single one-time infusion of CAR-T that was manufactured within 48 days, reducing vein-to-vein time to less than 10 days. 1/3 of the patients had extramedullary disease, 1/3 had high-risk cytogenetics, 60% were penta-refractory at a time of infusion, and 1/3 still required bridging chemotherapy despite reducing the vein-to-vein time to 10 days. A quick review of the CRS at different dose levels. You can see that a vast majority experienced cytokine release syndrome. Vast majority of these cases were grade 1 and grade 2, with only 10% having grade 3 or higher events. Median time to onset of CRS was actually beyond 1 week, and perhaps a reason for that was in vivo expansion that occurred late in these patients. Toci, corticosteroids, and anakinra was used in wide majority of patients for the CRS management. Again, all grades ICANS was 20%, with grade 3 ICANS around 5%. Cytopenias were seen with this CAR-T product as well, just as expected with previous products. Looking at the response rate with the updated phase 1 results, you can see responses varied based on the dose levels. Median follow-up was nearly 6.5 months. Time to first response less than 1 month. Time to best response 3 months. Many responses actually deepened over a period of time, with MRD negative responses being seen, speaking for the fact that this CAR-T undergoes expansion and perhaps better persistence as well. So authors very convincingly showed that CAR-T cells can be manufactured in a fast manner within a period of 48 hours with a vein-to-vein time of nearly 10 days, undergo in vivo expansion leading to late onset side effects including CRS and ICANS, and still preserved T cell stemness leading to persistence as well as deep and durable remissions. I think this platform is of a lot of interest, knowing the vein-to-vein time and need for bridging chemotherapy for the currently available CAR-T cell products, and will probably be further developed in future trials. In similar vein, investigators from China presented the results of phase 1 study of a dual targeting FAST-T CAR-T product, GC012F, that targets BCMA and CD19 on surface of myeloma cells in patients with relapsed refractory multiple myeloma. CAR-T products were manufactured within 36 hours, drastically reducing the vein-to-vein time, were infused in 29 patients with very deep and durable remissions lasting beyond 36 months. These CAR-T cells were again found to be persistent, nearly half of the patient at 12 months after infusion. The theme here seems very clear that there is a focus on developing CAR-T products that can be rapidly manufactured, that once infused undergo in vivo expansion, leads to better persistence and perhaps more durable responses, and that also translates into late onset side effects, including cytokine release syndrome, that allows for outpatient administration of these CAR-T products.